We'll let everybody find a seat. My goodness. Somebody forgot to tell them we were meeting this morning. Don't have many people in the crowd. Good morning, and I want to welcome everybody to the fifth and the final meeting of the Budget Review Subcommittee on Health and Family Services for the 2023 session. As a reminder, no remote attendance by members is permitted. All members must attend in person to be recorded as present. And the meeting materials were put online earlier in this week, and they were made available for downloading, so that people could review all of these things. It looks like we do have a quorum this morning, so we are duly constituted to be able to do business. And with that being said, I would ask the secretary to call the roll.
Senator Berg, Senator Tichenor, Representative Bowling.
Here.
Representative Fleming. Representative Raymond. Representative Wilner.
Here.
Senator Mays Bledsoe. Senator McDaniel. Representative Petrie. Representative Reed. Representative Heverin. Representative Moser.
Here.
Representative Bentley. Chair Douglas.
Here. Thank you very much. Thank you very much, Mr. Secretary. With that being done, next we'll have to approve the minutes from our October 18 meeting. Do I hear a motion?
Second.
Okay. Did you get those? Okay. The minutes have been approved. With that being done, I'd like to start off my meetings the same way every time. We are here to do the business of the people of the Commonwealth of Kentucky. And with that being said, for those presenters who will be presenting, I always ask that acronyms not be used. You may know what they mean, but many of the people who are listening, either on the radio or who are watching this on the visual media, will not have a clue what you're talking about. And since we're doing their business, it is in our best interest and their best interest that they be able to understand what it is that we are talking about. Also, I really do. We all take this seriously, and we're looking at money that our taxpayers are giving and entrusting us with. So we want to make sure that we are the people who are doing the best we can for those people who have entrusted their money to us. And I would ask that we always keep that in mind as we go through what's being presented and as we come up with and formulate questions regarding what is being presented. With that being said, the first item on the agenda this morning is a presentation from Missy Runyon and Sarah Cooper with the Cabinet of Health and Family Services. They will provide an overview of the Community Mental Health Services and Substance Abuse Prevention and Treatment block grants. So please present yourselves up front here. I would ask members to hold questions until these two young ladies have made their presentations. I know that you all have done a little bit of this before, and I wanted you to come back because I didn't think you had time to do what you previously had started. I didn't want you to feel rushed. So if you would please, just tell the audience who you are.
I'm Sarah Cooper. I'm the Legislative Director for the Cabinet for Health and Family Services.
And I'm Missy Runyon. I am the Block Grant Program Administrator in the Division of Mental Health.
Thank you, ladies. Would you please raise your right hand? Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth?
Yes.
Yes.
Thank you very much. You may proceed.
Okay, thank you. I'm here to talk about our block grants that we receive in Kentucky for both substance use disorders and for mental health disorders. And I know I presented this material before, and I appreciate the chance to. I'm just going to go a little slower and make sure we cover everything. We do use a lot of acronyms, and I appreciate the mention about that because we remind people of that all the time as well. So if I use acronyms, stop me. Basically, you can go ahead one. Our block grants are grants that all the states and territories receive, so they are non-competitive, but they are restricted to certain population bases, and that's what we're going to talk about a little bit today. We submit a large application every 2 years, and that is what I presented last time, was talking about our application. In between, we do little mini applications, and in order to get these funds, we have to submit that application and plan and get that approved, and then we have to do annual reporting. And we also participate in site visits by our Substance Abuse and Mental Health Services Administration. That's the SAMHSA that's on this slide. And they will come and visit like every 4 years or so and make sure that states are doing things correctly with these funds. Funds can only be used for the plan as submitted, and they can be used to evaluate the services and the programs that you're providing, and you can do planning, you can do educational activities, training, those kinds of things with these funds. I forgot to mention, but the application that we submit is a combined application. So we send in one application for both the mental health block grant and the substance use prevention, treatment, and recovery services block grant. But then our reporting that we provide is done separately for each block grant. Both block grants must be directed toward these 4 purposes. We must fund priority treatment and support for people who don't have insurance or who might go in and out of having insurance. And we must fund services that demonstrate that they work and provide good outcomes and support recovery, and services that are not covered by other insurance streams. We must fund primary prevention. And primary prevention for substance use means that you're providing services that will help someone from developing a substance use disorder. So some of these funds are used specifically for that purpose, to try to prevent substance use disorders. You can do other prevention services as well. And then, as I said, you can collect your data that you need to determine how well the programs are working and what your outcomes look like. As I mentioned, there are 2 block grants that we're talking about, and these are the 2 block grants. Also, so every year we receive these 2 grant fund streams. But underneath there, you will see some of the extra funding that over the last few years during the COVID era, we received extra funding, and that is what is listed under. And most of these we receive for both block grants. The only exception is the last one on the list, where it says Bipartisan Safer Communities Act. That was an act specifically for the mental health block grant only. So we received a supplement, and we'll talk more about that as we go. So to dig in a little bit for the mental health block grant, so the requirements, the restrictive part, is it's only for community-based services, so you can't use this for inpatient care. And it's only to be used for individuals with serious mental illness or for young people with serious emotional disability. 10% of those funds that we get for the block grant, for the mental health grant, must be used for early interventions for first episode psychosis, and you must use a best practice model. So the coordinated specialty care model is the one that's used nationally that's been shown to work with that population. So we must use some version of that model. 5% set aside must be for crisis services. So again, we're targeting the folks that have serious mental illness or serious emotional disability, but you can go a little broader for your crisis services because, again, we're trying to take care of all the mental health needs out there in the community.
Ms. Runyon, if I could interrupt
Yes.
a little bit. only I get to do this right now. Could you help me a little bit with who within the Substance Abuse and Mental Health Administration, Mental Health Services Administration, makes the decision? Who makes the decision who will get to disperse that money?
So say that one more time.
The grants come in,
Yes.
and then those grants are dispersed.
Okay.
Help me with a couple of things. Who makes the decision who gets the grants? Because people they apply and qualify. And then once we know who is getting those grants, who makes those decisions as to which groups, because those grants go out to different groups.
Yes.
Who makes that decision as to which groups get part of that funding?
Sure. Okay. So primarily our department, the Department for Behavioral Health, Developmental and Intellectual Disabilities, we have leadership teams that are built in, and they work on I call them allocations of these funds. And so, it's a process. You wait and see how much you're going to get, and then you have to figure out how to provide. I will say, for speaking mental health block grants specifically, as I say, you are restricted to serving serious mental illness and serious emotional disability. And for us, we have a safety net, which are our community mental health centers. And so primarily about 80% of the funds that come in go to those community mental health centers. And so they have various programming that serve these restricted populations. Others, we do fund others, and it happens differently based on need. We look at the providers that are out there, and like you said, some of them go out as they have to apply for funds and see if they're appropriate to receive those, if they're serving the right populations, those kinds of things. I hope that answered some. It's a complicated process, but basically it's our department leadership that decides how to allocate funds. And there are some historic formulations that we use based on service population and those kinds of things as well.
Thank you very much. That certainly is a start to the answer. And I apologize for interrupting. You
That's
go ahead
okay.
and proceed.
That's okay. It's a great question. As part of this grant, you also must spend, they call it maintenance of effort, and I'm sure you've heard those terms. You have to spend a certain amount of state dollars on these populations, on mental health, in order to qualify to receive these grants. And then we also must spend a certain amount for children and youth. So there's a certain amount there. These are the priority populations. I've talked a little, but when I say serious mental illness, it's typically known as SMI. And this is the federal definition of that. So it's people who are 18 years or older that has a diagnosable behavioral health disorder and also has limiting functional issues such as basic daily living skills, work, school, those kinds of things. The same with children with serious emotional disability. This is the federal definition, so it includes people up to age 18 who have a diagnosis of a mental health disorder and has some school functioning issues, home issues at home. There are state definitions. Every state has their own definition, but it must at least fit it must at least fit the federal definition. In addition to the services for both of these populations, funds, like I said, can also be used for data collection, reporting, and other infrastructure. So just to look at the funding for the current year that we're in, this is just for the mental health block grant. The current allocation is $12,500,000. The president's budget is more for 24, but currently it's in Congress right now for them to decide what the state's final 24 allocation will be. And then we added some numbers here for maintenance of effort requirements. So for the mental health block grant, we must spend at least that amount listed of $20 million in order to qualify to keep receiving these funds. The children's services set aside, those are specific funds that are spent on just the children under this grant. And then again, our 10% of our final allocation for our early interventions for first episode psychosis and the 5% for crisis. Okay, and now I'm going to switch to the second grant, which is our Substance Use Prevention, Treatment, and Recovery Services Block Grant. This, again, is restricted to only community-based services, so it cannot be used for any inpatient services. It can be used for residential substance use treatment. That is considered community-based. 20% of the entire allocation must be used for primary prevention. And remember, I said primary prevention is what's used to prevent people from getting a substance use disorder. You also have a minimum expenditure for pregnant women with substance use disorders and women with substance use disorders who have dependent children. And then there's also a maintenance of effort for this grant where you must spend a certain amount of state funding on substance use disorder in order to qualify for this grant. The populations that are covered under this grant are pregnant women with substance use disorders, women with dependent children who have substance use disorders, persons who inject drugs, tuberculosis services, again for people who are seeking substance use services, early interventions for HIV or AIDS if there is a designated state. Currently, Kentucky is not a designated HIV state. There are only 3 states across the nation right now that have rates high enough that they have to designate some of their funds. And then Kentucky has chosen to focus on service members, veterans, and their families as well. So those people who are affected by substance use disorder are also a focused population for us to use with our funding. Here is some of our funding levels again for 23. This grant is a little over $21 million. The president's budget, as you see, is much more. And again, we're in limbo waiting on the final 24 allocation. The maintenance of effort requirement, so we must spend at least $9.3 million in order to continue getting this grant. We must spend that 20% on primary prevention, and we must spend at least $2.6 million on pregnant women and women with dependent children. Just to go through, these are our additional funds that are considered supplements to our 2 block grants that we received during the COVID era. I just made that up, the COVID era. So for this one, we call it CARA, but it's the Coronavirus Response and Relief Supplemental Appropriation. We were given 3 years to spend that, so it's going to run out March of 2024. And you can see the amounts. We received $10.7 million for mental health and $19.1 for substance use. Again, just to remind you, all of these supplements have all the same rules, and we have to serve the same populations. That's how it's folded under each block grant. We also have the American Rescue Plan of 2021, which we call ARPA. And we have 4 years to spend that, September 2021 through 2025. For mental health, we received $18.5 million, and for substance use, we received $16.4. Again, the same rules apply for that as well. This was a very different pot of money, but it was given as a supplement to the block grant, so we track it through our block grant. This was a much smaller pot of money that was given to each block grant only for mitigation of COVID-19. And so you can only use these funds to buy personal protective equipment, testing kits, to arrange testing procedures for your staff and for residential programming, for example. So things to mitigate the spread of COVID. And so as you can see, for mental health, we received $638,000, and for substance use, $562,000. And then the last one that we have received is the Bipartisan Safer Communities Act. And I explained that this one is only part of the mental health block grant. We received our first allocation. That's for a 2-year period of time, which ends October 24. And we have recently received a second allocation, and each of those are $832,000. We are told that it's been approved that we will get 4 total allocations. So we're expecting to continue to get that for, every 2 years. These funds, again, we talked about that, are designated to enhance mental health emergencies, crises, including natural and man-made disasters. And so these funds are through our mental health block grant, so they're intended for us to be sure that we are taking care of our individuals with serious mental illness and serious emotional disability during those times of crisis. We are required, these are called performance indicators, and so every application, every 2-year period, we must create things that we're going to measure for each of our required populations. And I won't go into detail on all of these unless somebody wants, but these are things like the first one would be for our adults with serious mental illness. So we're trying to make sure that folks remain in independent housing as much as possible. And so that's what that one is focusing on. We're looking at our provider workforce for children with serious emotional disability, and so on. So we must have one for each one of these populations. We actually have 2. I thought we had 2, but we only have 1 for prevention this year. We usually have 2. We have Plan of Safe Care is something that we've implemented in some of our community mental health centers to help pregnant women and women with dependent children. We're monitoring the syringe services programs across the state. That is to help with our folks who inject drugs. So that's that population. So again, I can go into more detail on any of these that you want, but we just have to have something that we're doing actively and measuring for each one of our required populations. A lot of info, a lot of stuff. Okay.
Ms. Cooper, you don't have anything to?
No, I'm the slide expert. I'm providing technical assistance.
Okay, I didn't want to not recognize you or give you an opportunity.
No, thank you.
Representative Wellner.
Thank you, Mr. Chairman, and thank you for the presentation and the detailed information. It's really helpful. So a couple of years ago, Dr. Bentley co-chaired a serious mental illness task force, and one of the findings that came out of that work was a severe statewide shortage of supportive housing for individuals with SMI, serious mental illness or severe mental illness. So I'm wondering if any of these grant dollars are being directed in that way, or if they could be directed in that way that aren't currently.
It's a great question, and I will say that our department has recognized that that's like one of the top issues. These funds cannot be used, of course, to buy housing. So you can't buy housing. But these are already being used for, and more can be used for supported housing services. So that is a evidence-based practice for this population, and there's a whole group of services that you can provide, and we do fund many of those services. But yes, there is a need for the housing piece. And so these funds cannot be used for that. But yes.
Absolutely.
Thank you. So, obviously, not to buy a house, but if there are
Right.
agencies that provide supported housing, housing where there are crisis managers on staff, where
Yes.
there's treatment availability, and we probably don't have enough of those facilities to begin with.
Right.
But to get people or to provide people treatment within those kinds of housing situations, is that allowed, and is money being used that way, and could more be used that way?
Yes, there is something we call residential supports, and that it's for people who are, even severe mental illness has its scale, and you have people that are way up here and people that are more in the middle. For folks that are have higher needs, and they may not be able to at that moment reside on their own. There are some of those housing needs that we call residential supports that we do fund across the state, and it allows at least 3 or 4 people to live in one home and have around the clock staff. And we do fund some of that from this block grant. So I would say yes, that's definitely true.
Would it be possible to get a report specifically of what funds, or from this grant or maybe elsewhere, but what funds are being used and how much to provide that kind of supportive housing? Because, it becomes a community safety issue as well
Yes.
as, a patient need issue. So I'd be very curious to get that information.
Yes, and I know people are taking notes, so I'm sure we can get that for you. Yes.
Thank you very much.
Yes, and it's a great question. It's a big need in Kentucky. Yes.
You're very welcome. Senator Berg.
Thank you, sir, and thank you both for the presentation. Is it possible, when somebody calls me on the phone and asks me for a contribution, my first question is, what percentage goes to administrative costs versus what percentage goes to direct whatever your charity is for? Do we have that type of data for the taxpayer dollars that we're spending? Do we know what our administrative costs versus our direct care costs are?
I'm the block grant administrator, so I can really only speak to the block grant, but I didn't put that in my presentation and should have. Only 5% of our total allocation for both block grants can be used for admin. And let me just tell you that we're under that. So, but we can definitely show you for block grant what the administrative costs would be. We can show you that, but it cannot be over 5% of either.
Thank you. If you called me, I'd give to you. That's an excellent, excellent answer. I really appreciate that. Can I make a statement?
Yes.
Just real quickly, something I know you all aren't the right ears to put this into, but I want to put this into anybody's ears that are listening. In Indianapolis recently, I'm a physician, so I go to the, National Count of Physician Legislators, and we meet. And one of the things, and I honestly at this point don't remember if it's Oregon or if it's Colorado, but one of the two states has been able to initiate free mental health care for every child in the state. They can either, they can either do it online or in person, in English or in Spanish. And guys, their suicide rate has actually declined. Everybody else is going up, 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 and they've actually been able to make an impact on their suicide rate. Is this something, is this just way too pie in the sky for Kentucky?
I am certainly not the person to answer that question. I was just I would say that while it sounds like a beautiful ideal, I think that's fabulous. There are considerations of we can't fund anything that is paid for, like if it's a Medicaid service that is in our Medicaid plan, that we wouldn't be able to, yeah. So there would be all kinds of things you would have to consider. Yeah, and it would definitely not be me making that decision. So, yeah, thank you for that information.
Thank you, Senator Berg. Senator Titchener?
Thank you. Thank you for being here. There was a statement that you made at the end of the presentation about the syringe program. I'm just trying to
Oh, yeah.
put this together. You said to help with our folks who inject drugs, and maybe you didn't intend for it to come across this way, but it kind of sounded like, that's something we want to encourage, which of course we don't want to encourage people to become, have a substance abuse disorder. So within the block grant, you have some money that's allocated for prevention and yet still some for the syringe program. Are we seeing, or are we able to track, and maybe Sarah, this is more up your alley, the data of success we're having in our prevention measures? Are we seeing decreases in our numbers of those who are recipients of some of this grant funding?
Well, I just wanted to respond to what I said earlier. I was explaining that for our target population of persons who inject drugs, that is the performance indicator that we chose to measure. Actually, block grant funds are not used for syringe services
Okay,
programs. And it goes through. So we do monitor those, though, through our public health is the one. And then I know that we have substance use prevention data. I don't have that with me, but if you could give us a more specific idea of what you would like to see, we can try to have that for you.
I think it'd be interesting to know over the years of receiving this block grant and the money we're spending towards prevention, if we're seeing some success and results from the money that's being spent in that way. So
Great question.
thank you.
We can work on that. Yeah.
Thank you very much. Representative Mosier?
Thank you, Mr. Chairman, and thank you for being here. I have a few questions, and I think my question about prevention was more or less answered. I know that this doesn't fund syringe access programs, but syringe access programs do more than just give out clean needles. So we know that they actually work to get people into treatment. So, yes. And I think the public health departments do track that data. So we should be able to get that. But I had a couple of questions. I guess one, back on the residential supports and supportive housing. Are we, do any of these funds, do we use personal care homes as some of those residential or supportive housing areas for our severely mentally ill population, transitioning specifically, you talked about transitioning from our state hospitals to other housing. Mm-hmm. Do we utilize personal care homes for that?
For block grant, that would be prohibited because, again, it's community-based services only, and personal care home wouldn't fit under that. So really what we are trying to do is move people from the personal care homes into community-based housing. So we fund a step down from that, which I'm calling residential supports, and those are these
like a group
3-person homes. Yes.
Sure, yeah.
Yeah.
Which is fine, but I know that you all have to deal with the outcome of the Olmstead Act and getting folks into the community, but they're not always being appropriately placed, and that's my concern. We have personal care homes, and yet we aren't, I don't feel, utilizing them like we could to really provide more supportive housing. So I don't know, this may not be the appropriate block grant to deal with that, but if we could find a way to allow for appropriate communal living, because these personal care homes are our home to folks who have nothing else. So I just think it's an underutilized resource that we could really bolster in some way. And then, Mr. Chairman, if I could ask one more question.
Yes, go ahead.
Thank you. You talked about 80% of these funds go to community mental health centers. Who provides the oversight of the treatment received in the community mental health centers? Because I know regionally they're different, and obviously we need to tailor that treatment to individuals. But who monitors the success or treatment in those programs?
Well, we have a very large system that does that. So all of the funds that we received have to be contracted out to providers. So each of those contracts are monitored, and they're monitored. It's a very complicated process, but they're monitored by the program administrator level. But we have a whole division called Program Integrity in our department, and they have a program support branch that does contract monitoring. So they work with the program administrators in our divisions, and try to hold folks accountable that way. So we do have, and it's a lot of contracts and a lot of monitoring, but we try to do that well. So
Okay. And you feel good about that? It's going well?
I think our new commissioner's going to make that even better. But yes, I think, we have lots of staff that work on that, and yes.
Perfect. Okay. Thank you.
Thank you very much, Representative Mosier. I held mine. I just have a couple here in the last. I want to share a little concern I have that you repeated that you must spend the money each year, and I think you guys are probably smart enough to know what needs to be addressed, or at least have enough good people working with you. What needs to be addressed and what doesn't, and I know that calamities come in a cyclic type of fashion, and I wish there was some way we could modify some of those things, because not all the money gets spent as best it could sometimes when you're having to find places. Yeah, you can smile. I've been there too. When you're having to find places to have to spend that money, but I want to thank you, ladies, for being diligent and doing that. The question I really had was, do we have any idea of taking a look at the people who are being served here, and looking at population versus participants in the programs? Sometimes we tend to serve the same population, but we don't see individual turnover within those populations. And since these grants are supposed to be helping people move away from needing the grants, is there any way we follow who actually exits the program?
I don't know the answer to that. But I just to make sure I understand, you're talking about, like, if we're counting how many individuals with serious mental illness got served, you're saying that how to monitor that wouldn't be the same people getting served every year.
Well, there are actually people who have mental illness who improve.
Yes.
And who don't require this. And I know sometimes, the population thinks once a mental illness, always a mental illness. Well, we know that's not true, those of us in the healthcare space. And I didn't know if we had any way of monitoring how many people were exiting that particular space of mental illness.
And I don't know the answer. I would have to check on that for you.
Okay. All right. Thank you very much. I'm not going to have you do that. I just want to throw that out for a thought process. The other thing I want to say before I let you ladies go is that for the people who are monitoring money, there are no free healthcare programs. The money is not automatically coming out of the air. Someone's paying for it, and so that's one of the things I think that we need to keep in mind, is that there are no free programs. We have to make sure that we monitor the programs that we're approving, and the money that we're approving for these particular programs, to make sure that those programs are in fact doing what those programs were set up to do. But I do want to thank you ladies so very much for presenting this morning. And with that being said, we'll bring our next presenters up here. Thank you very much.
Thank you very much.
Next, coming up, we will have Commissioner Lee and Director Angie Parker with the Department of Medicaid Services to provide an update on Medicaid Managed Care Chronic Disease Management Pilot Program, which was included in Budget Bill, that is House Bill 1 last year. So as you ladies come and get comfortable, I want you to make sure that your microphones are on, and if you please will introduce yourself for the audience.
Good morning. I'm Lisa Lee. I'm the Commissioner for the Department for Medicaid Services.
Good morning. I'm Angie Parker. I'm the Director of Quality and Population Health.
Is that microphone on? Or you may want to pull it a little closer to you. Okay. If you both raise your right hands for me, please. Do you solemnly, wait a minute. Thank you.
My first time.
Are you
Raising
all
my
testing
hand.
me to see if I'm paying attention? Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth?
I do.
Thank you very much. You may proceed.
So, good morning. Again, when I start my presentations, I always like to give just a little bit overview of the Medicaid program. So, just to get that kind of framed in our mind as we talk about some of the initiatives that we're doing going forward. The information here is from July, but still a little bit almost the same numbers. We currently serve 1.6 million members in the Department for Medicaid Services. That's approximately 1 out of every 3 individuals in Kentucky. We serve over half of the children in this state in either Medicaid or the Kentucky Children's Health Insurance Program, which is KCHIP. We also have 614 expansion members. Those are members that are aged 18 to 65 whose incomes are at or below 138% of the federal poverty level. We have over 69,000 enrolled Medicaid providers delivering services to our members, and that includes both in-state and out-of-state providers. In fiscal year 23, our total expenditures on both services and administration was about $16.8 billion, and of that, around in our fee-for-service population or in our administrative cost in the fee-for-service arena, which is those individuals that are served in Medicaid, home and community-based waivers, and long-term care facilities. Our administration costs for delivering services in the programs are about 2% of our budget. So we want to talk about chronic disease today. We have some information here related to chronic disease in Kentucky. As you can tell from the chart here, this is from America's Health Rankings. Kentucky ranks 48th in the nation with 15.6% of our population with 3 or more chronic conditions. We've listed those here. Of course, we know that all of these conditions are very familiar to us, but 15.6% has chronic conditions. We know that the bulk of those individuals are in the Medicaid program, but this is every individual in Kentucky. It is not just the Medicaid population. We do hope that some of the information that we're going to present today and talking about some of the pilot programs, that if once we get information on those programs and the success of it, that it will spill over into the general population in Kentucky to help lift up and elevate the health status of all Kentuckians. House Bill 1, passed in 2022, had provisions that stated Medicaid would implement a pilot program to manage and reduce outcomes of chronic diseases experienced in the Medicaid program. We would like to see, of course, have behavioral health changes as real-time monitoring, such as cell phones. So the bill stated that we should do pilot programs that have monitoring devices so that providers could remotely monitor patients with certain healthcare conditions. And we have to require each managed care organization to participate in those pilot programs. So Section 34.1B of all managed care contracts contains language that states every managed care organization shall have some sort of process, policies to help individuals who have been identified with one or more chronic conditions. The aim of this contract language is to reduce the healthcare cost associated with taking care of those individuals with chronic conditions, but more importantly, to improve the quality of life for those enrollees. So remote patient monitoring, or RPM as it's sometimes called, is a process whereby individual organizations would supply certain devices for individuals so that providers could monitor healthcare status such as blood pressure or certain things like glucose monitoring remotely. Could also include cell phones and programs that help individuals with diabetes, for example, to monitor what they eat, to look at their sugar levels, exercise, that sort of thing. There are over 111 companies out there today that offer these sorts of remote patient monitoring devices and programs. The department cannot directly contract with any of those organizations without first going through a request for proposal following the procurement process, because we couldn't select one over the other. However, beginning in 2022, when we started unwinding from the public health emergency that's related to COVID, we updated our telehealth regulations and we expanded some provisions in our telehealth regulations to cover remote patient monitoring for a variety of conditions, not limited to pregnancy, diabetes, heart disease, some of those chronic conditions that House Bill 1 was trying to address when we talked about the pilot programs. Currently, we do have a variety of pilot programs within the managed care organizations. All 6 managed care organizations are doing a variety of pilot programs. The average number per MCO is 5. We have 5 MCOs who have pilot projects specifically related to diabetes. Other pilot programs that the MCOs are conducting are related to hypertension, heart failure, coronary artery disease, asthma, depression, kidney disease. And so we do have 3 specific pilot programs with remote patient monitoring. Aetna has remote patient monitoring for individuals with they, for example, monitor your blood pressure cuffs. They have weight scales, glucometers, pulse oximeters that they monitor individuals who have chronic conditions. Anthem utilizes the LARC Diabetes app. That is an application that individuals download on their phone, and they insert information. The phone helps them with their weight, tells when they can log when they exercise, gives them some prompts, for example, to say, if you haven't exercised today, would you, so they can monitor all of those informations through that LARC app. And then United utilizes a digital remote monitoring for members with hypertension and diabetes. And so have brought Ms. Parker with me today because in 2022, the Department for Medicaid Services underwent a reorganization, and we specifically created a division of population health and quality outcomes. While we've always had a focus on quality, we think this elevates it a little bit higher, and it's, we definitely want to start monitoring those individuals with chronic conditions and make sure that we're doing everything we can to help them manage their conditions and improve the health status of our members. And very recently, Ms. Parker was instrumental in assisting Kentucky in being one of a few states that is or we're participating in a program related to continuous glucose monitoring. We know that a lot of our population in Medicaid has diabetes or is pre-diabetic, and so I brought Ms. Parker here to talk a little bit about that initiative related to our continuous glucose monitoring project.
And she also brought me for comic relief, I think. But so yes,
And you're doing a great job.
Thank you. So, as the commissioner stated, we were awarded with 7 other states the ability to expand access to continuous glucose monitors and to transform diabetes care for our Medicaid beneficiaries. That diabetes has been a first and foremost program that we've looked at since I've been with Medicaid. So we all know that the majority of Kentuckians, unfortunately, are diagnosed, my husband being one of them. So I'm very familiar with the continuous glucose monitors and what they can do to help in facilitating increased outcomes for our diabetic population. But what this basically does is we will it's a technical assistance and peer learning with the other states on what all other Medicaid agencies are doing and how we can move that needle regarding insulin-dependent diabetics. And this just was kicked off. We had a kickoff a few weeks ago. A press release should be coming out very shortly regarding this, but we're very excited to see how, and actually Medicaid's probably a little bit ahead of some of these states, so we're going to actually be able to teach them too on the utilization and criteria for continuous glucose monitors. The other states are Iowa, Kentucky, us, Michigan, New Jersey, Oklahoma, South Dakota, and Texas. So that's a $75,000 grant, and more to come on that. Look forward to letting y'all know more about that.
So we do know that the population in Medicaid in Kentucky is definitely has more medically complex needs than the rest of our population. But again, hopefully some of these pilot projects that are going on and our continuous glucose monitoring grant will help us not only improve the health status of the Medicaid members, but it will also have a spillover effect into some of the individuals that are not enrolled in Medicaid, and hopefully serve as a model for some of our commercial carriers as we go forward. And with that, we would be happy to take any questions.
Senator Berg.
Thank you, Mr. Chairman, and I'm sorry. Can you just, this continuous glucose monitoring, can you tell me the details? Are we giving, how do we do it?
Well, basically, we'll be meeting with each of the states to evaluate what their benefits currently are, or if, what their criteria is for utilization, and is it being utilized? Are insulin-dependent diabetics, where are they? Should they be getting a continuous glucose monitor? There's going to be a lot of data involved, which is why there's a technical assistance in this program, but it's basically education for all of us on what works. Does continuous glucose monitor actually improve our members with diabetes?
So right now,
access.
Medicaid patients are not eligible for glucose monitoring? They are.
They are. Mm-hmm. Which, like I said, we're a little bit ahead of the curve than some of these other states, so we're going to be able to share our information as well on how it has or has not worked for our diabetics.
Okay, thank you. Just a quick note. Yeah, I thought continuous glucose monitoring for controlled diabetes was already established.
We do have controlled glucose on. We do cover those in the Department for Medicaid Services. What this initiative is going to do is help us discover the success rate not only of those individuals who have continuous glucose monitors, but have a profile of those individuals and make sure that that their success with the continuous glucose monitors is documented, that we have that clear picture of the success rate of those monitors and who is most likely to benefit from those as we go forward.
All right, thank you.
Help us identify those that probably should be,
but are not
on a CGM, continuous glucose monitor.
Senator Tishner.
Thank you. I'm just shocked by these numbers. I absolutely can't believe 15.6% have 3 or more chronic conditions in the state of Kentucky, and we're ranked 48. That's really, really depressing to me. And maybe this isn't your department or your job. You guys do a lot with monitoring and management. Is there anything that you're working on for prevention? Most of these chronic conditions are preventable. Diabetes, I would venture to say the majority are type 2 that you all are talking about. That's, lifestyle changes. What are we doing to get have a better ranking and lower these numbers?
Well, I can say I'm a very competitive person, and the fact that we are at 48th, and as a state, it's not just Medicaid, but this area is very passionate about, because of the fact that we do look so bad. Certain areas we're better at, we're not. But to answer your specific question, what are we doing to prevent it? We're getting ready to roll out a value-based payment program for our MCOs that five measures. One of them is controlling their diabetes through their hemoglobin A1C, which is a diabetic lab for those who may not know, and to get it under 8. It should be really around 5.5, but living with a diabetic to get him to 8 would be tremendous. Also, childhood immunizations and adolescent immunizations for the preventive for other future diseases, well-child visits, and social determinants of health. So those are things that they are to improve upon. They're based on HEDIS measures right now. We're looking at that. And they have to get a 3% improvement each year in order to get a portion of a capitation that is, we're holding back a 2% cap payment for them in order to meet these quality measures. So they're to show some improvement in those areas. And there's a bonus pool associated with that too. So if they meet all 4 out of 6 of them, they can, which includes breast cancer screening, follow-up from emergency department for behavioral health or SUD diagnosis. I know all these, but there's a couple of more.
We can get those specific measures. The other thing that we're doing, I know as many of you all are aware of the House, I forget the exact bill number, but it was the Hospital Reimbursement Improvement Program. That is a program that allows the Department for Medicaid Services to pay enhanced rates to the hospitals across the state. As a condition of them receiving those enhanced funds, they have certain quality measures that they have to meet, and most of those are related to prevention, such as screenings for mental illness, for behavioral health, and well child checks. A variety. I think there's a list of about 10 to 15 quality measures. We could get those for you if you would like to see all of those measures. And that includes all the hospitals in Kentucky plus the universities.
Yes, that's been in the works for the last couple of years. So, it takes time to move that needle, but, I hope we can get to that point while I'm here. So, yes. Appreciate the question.
Representative Wilner?
Thank you, Mr. Chairman. And Commissioner Lee, since you're here, if you and the chair will indulge me in asking a question that's a little off of this immediate topic. But I'm curious about the waiver for housing waiver for SUD. I'm sorry, the housing waiver for people with serious mental illness. I know that's been in the works for a while, and just wondering what the progress is on that.
We are making progress on that. It is. I think there was a presentation this morning. Leslie Hoffman, who is their deputy commissioner, is leading that initiative up for the department. She would be able to speak more to that. But we know that, Medicaid cannot pay for housing, but we can pay for housing supports, such as assisting individuals with finding housing and that sort of thing. But be more than happy to provide an update with you on that specific topic.
Thank you. I would appreciate that.
Representative Mosier?
Thank you, Mr. Chairman. Thank you so much for having this conversation. I love talking about population health and prevention, and it's something that we talk about all the time, and it's difficult to really quantify the return on investment ahead of time. I mean, we know that this pays dividends to catch things early, and I just want to talk about some of our cancer screening programs that we've implemented in the last couple of years. I mean, colon cancer has been ongoing for about 10 years, and now it's a Medicaid covered service for early screening. And just catching these cancers early is not only cost effective, but changes the trajectory of a person's life. I spent yesterday in a strategic planning meeting talking about the lung cancer screening advisory program that we've put in place. And not to go into the mission, vision, and all the things that we spent all day talking about, but there is some embargoed information that I'm hearing about that Kentucky will be moving from number 4 in the nation in terms of screening to number 2. So we are making great progress in catching lung cancer early. And, we know that when we catch things, do this low dose CT screening, that we're catching these cancers at stage 1 when it's very, very treatable. So I just want to, share some good news, because we do hear a lot about our horrible health metrics. But I think you're right. All of these programs take time, and we're having more and more of these conversations and really targeting some of our Medicaid dollars specifically to programs that we know work. So I'm excited about the future. I think that we're making. Thank you.
Thank you, Representative Mosier. One of the things I did want to follow up regarding that committee is that the Lung Cancer Screening Committee, it's because of the intelligence that they have on that Lung Cancer Screening Committee, the people on the committee, that really is the reason. 56% of the population of the Commonwealth of Kentucky have 3 or more chronic conditions. Is there any way we can get more exact numbers as to the percentage of people who are on Medicaid who fall into that particular category here in the Commonwealth? I really would like to have that data, not as a shaming. I'm a physician. I simply look at numbers, and when we target populations, I want to know how that population is doing in comparison to other populations. And it's not meant to be discriminatory. It's meant to be factorial and helpful to me as a physician. So if there's any way we could get some of those numbers, I would love to see that. The other thing, we look at the LARC app monitor, and one of the things I want to caution people on or about, and I've done this over and over and over, we look at the quality of what our healthcare system is offering, and we can improve that as much as we want. But until we actually look at the outcome, which is not based on what we're doing so much nowadays, it's based on what those participants are doing. And I really want us to start having that conversation, especially in this space, because our numbers continue to go up, although we can argue that some of the numbers are coming down, but there are some other reasons for those numbers coming down. I just want us to make sure that we are taking a look at the appropriate things that we need to look at in order to improve the health care that we have in this state. Because I want to remind the people of the Commonwealth that 48 out of 50 doesn't mean we're number 2. Okay, some people may see it that way. But it isn't that way. So, Senator Berg.
Thank you, Mr. Chairman. And I just want to make just a brief comment for everybody so that we can feel maybe just a little better about ourselves. Yes, we are 48th in the country for overall health. But guys, during the pandemic, we soared. And we pulled so above our weight. I haven't checked the last numbers, but I think we were number 18 as far as deaths per population. So, we might not be doing everything right, but guys, we did that right. And we showed the country 48th in the country as far as baseline wellness. And we were in the top % of states that managed this pandemic. I just want to say that. Thank you.
Well, Ms. Lee, Ms. Parker, I want to thank you all so very much for the information that you've given us this morning. If there are no other questions from members of the committee, our final amount of the thing that business that we have this morning is a motion for adjournment. Do I have a second? Well, thank you all for being here this morning.